Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a sports physiotherapist called Chris Maloney giving a presentation in which he describes treating a high jumper with a knee injury. You now have 90 seconds to read questions 31 to 36.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she'd stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain, so I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on to the next...
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a clinical psychiatrist called Dr. Anthony Gibbens giving a presentation about the value of individual patients' experiences and stories in medicine. You now have 90 seconds to read questions 37 to 42.
Hello, My name's Anthony Gibbens. I'm a clinical psychiatrist and published author. I'd like to talk about something that's relevant to all medical professionals, the use of narratives in medicine. Let me begin with a case study sent to me by a colleague who shares my interest in the subject. The study featured a 30-year-old man who was hospitalised for severe panic attacks. He was treated with narcoanalysis, but feeling no relief, turned to alcohol and endured years of depression and social isolation. 4 decades later, he was back in the psychiatric system, but for the first time he was prescribed the antidepressant Zoloft. 6 weeks later, he was discharged because the panic attacks and depression had disappeared. He lived a full life until his death 19 years later. If the narrative was striking, it was even more so for its inclusion in a medical journal. Repeatedly, I've been surprised by the impact that even lightly sketched case histories can have on readers. In my first book, I wrote about personality and how it might change on medication. My second was concerned with theories of intimacy. Readers, however, often used the books for a different purpose, identifying depression. Regularly, I received and still receive phone calls, people saying, "My husband's just like X," one figure from a clinical example. Other readers wrote to say that they'd recognised themselves. Seeing that they weren't alone gave them hope. Encouragement is another benefit of case description, familiar to us in an age when everyone's writing their biography. But this isn't to say that stories are a panacea to issues inherent in treating patients, and there can be disadvantages. Consider my experience prescribing Prozac. When certain patients reported feeling better than well after receiving it, I presented these examples first in essays for psychiatrists and then in my book, where I surrounded the narrative material with accounts of research. In time, my loosely supported descriptions led others to do controlled trials that confirmed the phenomenon. But doctors hadn't waited for those controlled trials. In advance, the better-than-well hypothesis had served as a tentative fact. Treating depression, colleagues looked out for personality change, even aimed for it, even though this wasn't my intended outcome. This brings me to my next point. Often, the knowledge that informs clinical decisions emerges when you stand back from it, like an impressionist painting. What initially seems like randomly scattered information begins to come together, and what you see is the bigger picture. That's where the true worth of anecdote lies. Beyond its role as illustration, hypothesis builder, and low-level guidance for practice, storytelling can act as a modest counterbalance to a narrow focus on data. If we rely solely on evidence, we risk moving toward a monoculture, whereby patients and their afflictions become reduced to inanimate objects, a result I'd consider unfortunate, since there are many ways to influence people for the better. It's been my hope that, while we wait for conclusive science, stories will preserve diversity in our theories of mind. My recent reading of outcome trials of antidepressants has strengthened my suspicion that the line between research and storytelling can be fuzzy. In medicine, randomized trials are rarely large enough to provide guidance on their own. Statisticians amalgamate many studies through a technique called meta-analysis. The first step of the process, deciding which data to include, colours the findings. Effectively, the numbers are narrative. Put simply, evidence-based medicine is judgment-based medicine, in which randomized trials are carefully assessed and given their due. I don't think we need to be embarrassed about this. Our substantial formal findings require integration. The danger is in pretending otherwise. I've long felt isolated in embracing the use of narratives in medicine, which is why I warm to the likelihood of narratives being used to inform future medical judgments. It would be unfortunate if medicine moved fully to squeeze the art out of its science by marginalising the narrative. Stories aren't just better at capturing the bigger picture, but the smaller picture too. I'm thinking of the article about the depressed man given the drug Zoloft. The degree of transformation in the patient was just as impressive as the length of observation. No formal research can offer a 40-year lead-in or a 19-year follow-up. Few studies report on both symptoms and social progress. Research reduces information about many people. Narratives retain the texture of life in all its forms. We need storytelling, which is why I'll keep harping on about it until the message gets through.
That is the end of Part C. You now have 2 minutes to check your answers.